Ladies and gentlemen, let me welcome you to this annual lecture here at the Royal Society. My name is Gus O'Donnell. I'm president of the Institute of Fiscal Studies. And first, a couple of points about the IFS. Some good news and some sad news. The good news is that the IFS has achieved the status of an institute. This is really important. Bequeathed by the ESRC. There are only two. It's the IFS and CEP. People will know the CEP, Centre for Economic Progress. And that's fantastic news. Fantastic news for the IFS in terms of funding, fantastic news in terms of recognition for all the brilliant people that work in the IFS. So that's great. The less good news, the sad news, really, which I should note as a former council member, is the death of Jim Merlis. Jim was really instrumental in the IFS. If people will know the Merlis Review on taxation, they'll know that he was a council member, that he won a Nobel Prize. What you may not know is that probably the most intimidating 45 minutes of my life was when Jim Merlis interviewed me for whether I would be allowed to do the postgrad course at Nuffield College at Oxford, and that was very scary, I can tell you. But he let me in, so I've been grateful to Jim ever since. So tonight, we are delighted that Professor Janet Currie has agreed to give this year's lecture. She is the Henry Putnam Professor of Economics and Public Affairs at Princeton University, Director of Princeton's Center for Health and Wellbeing. She also co-directs the program on families and children at the MBER. She's very well known for her work on the impact of poverty and government anti-poverty policies on the health and well-being of children. She's written about early intervention programs, and I'll be keen to know what her views about Sure Start was, because that was very much something I remember from time in government. And she's worked on things that are even before Sure Start, the fetal origins hypothesis. I loved the title, which Richard pointed out to me, the article Killing Me Softly, the Fetal Origins Hypothesis, looking at shocks very early on. And the final conclusion, the fetal origins hypothesis has not only survived contact with economics, but has flourished, which I thought was pretty amazing. And then looking at some of the other work she's done on the impact of various policies, pointing out that while children can be permanently damaged at an early age by various things going wrong, an important message is that the damage can often be remediated, that we can put things right. And as someone caring about public policy, it's fantastic to know that there are things we can do on the positive side as well. So I will hand over to Janet. The idea is she will lecture for until around 7:30. Then we'll have half an hour for questions. During that time, please say who you are. There'll be mics which will circulate. And then if you're all very, very good, you get to have drinks after that, right? But it requires the first part. So Janet, we're delighted to have you. Over to you.
So thank you very much for those kind remarks, and thank you for inviting me. I'm very happy to be here. It's a great honor, and thank you all for coming to hear what I have to say. So my title for today is talking about life, death, and mental health, and more specifically, how access to care helps children succeed. So it is a positive message, I think, on the whole. So my lecture is going to have three parts. I'm going to talk at the beginning about how inequality and mortality in the US declined among children and approached already low levels that we see in Canada. I'm then going to talk about the US expansion of public health insurance for pregnant women and for young children, which I think was largely responsible for this improvement, and is a good case study if you want to know what are the effects of providing health care for children. And then in the last part of my talk, I'm going to talk about how mental health may be one of the important drivers of these positive effects of health insurance that we see. So we've seen a lot of research recently, I understand here in the UK as well, about stalling life expectancy, increases in inequality and mortality. And of course, there's been a lot of research like that in the US also. People like Raj Chetty have been writing about this. Ron Lee chaired a National Academy of Sciences panel talking about this. And very famously, Anne Case and Angus Deaton have written a series of papers talking about deaths of despair and how this is driving this increase in inequality and mortality. And I want to point out that most of this literature focuses on adults, usually using data for people over 45 or over 50. And it mostly focuses on non-Hispanic whites. So it presents a very clear picture, but only part of the picture. And this has attracted a lot of attention in the media, not just in the research community. Here's what I would say is a fairly typical article about this from the New York Times. The headline is that disparity in lifespans of the rich and poor is growing. They have this picture of a child, right? Keep in mind all the research is about adults, none of it is about children, but the implication is that, this child is going to face lower life expectancy than in past generations. And then kind of at the bottom, they throw in, researchers debate whether expanding access to healthcare will shrink the gap in life expectancy between the rich and the poor. So the sort of underlying message here is that there's some social force that's causing this increase in inequality, and even if you throw more healthcare at it, it's probably not going to do any good. Okay? Now, in some work with Hannes Schwant, we've tried to push back on that a little bit by looking at all deaths at all ages, not just deaths for middle-aged and older white people. And the way that we can do this is by realizing that every death is associated with a place. Okay, so in contrast, if you're trying to look at deaths by income or deaths by education, then you have an immediate problem in that you don't have income and education for children. And also, the way that people are selected into an income group can change over time and depend on how closely they are tied to the labor market. So if you're thinking about children, the disabled, or groups with weaker labor force attachment, like women, that can be a problem. So what we do is we take all US counties, rank them from richest to poorest, and then put them in groups or bins that each account for the same fraction of the US population. And then in each census year, we can say, well, let's compare, say, the bottom 5% of the population with the top 5% of the population. And the reason I'm making a big deal out of these bins is because this gets around the problem that depressed areas are often shrinking areas, whereas booming areas tend to be growing areas. So you want to do something to fix the size of the population that you're comparing. So if we do this for, in this example, male infant mortality, you get a picture that looks like this. I'm going to show you a bunch of these pictures, so I'm going to take a little bit of time to explain this one. So on the x-axis here, we're ranking by poverty percentile. So these are the richest counties, and these are the poorest counties. So not too surprisingly, the lines slope upwards, which is showing that infant mortality is higher in poor counties than it is in rich counties. Okay? Now there's 3 lines, one for 1990, one for 2000, and one for 2010. So another thing that you can see is infant mortality has fallen, and it's fallen more in the in the poor places than in the rich places. Okay, so if things have gotten better faster in the poor places than in the rich places, that means that inequality and mortality has fallen for these infants. I also, just out of curiosity, looked at the same thing for England, just ranking by health authority and sort of income levels in the health authorities. And what you see is a somewhat similar pattern. Improvements in infant mortality between 1990 and 2010. from a much lower level, I should say. So in the US, it was going from 10 to about 17, and here it's going from 6 to 10. But these lines are shifting in a much more parallel way than the ones that we saw in the US. Okay, so the fact that inequality and mortality is shrinking in the US in this group seems to be a little different than what's going on here. Okay, so if we start looking at every age group and different demographic groups, you get a picture or a bunch of pictures that look something like this. So this is for age 0 to 4. I have white females, black females, white males, black males. The lines are kind of the same as before, only there's one difference in that I have 2 lines for 2010. The reason for that is that in the 2010 census in the US, people are allowed to choose more than one race. You don't have to be white or black. You can be white and black. And for children, increasing fractions of people are being identified that way by their parents. It's 20% of infants. So it actually matters when you're calculating a mortality rate what you put in the denominator. And if you put all the mixed race people in, you get a lower rate than if you leave them out. So that's what these green and red lines are showing. Okay? But overall, what you see is a decline in mortality between 1990 and 2010. The decline, again, is greater in the poorest places, especially for males, than it is in the richest places. So you have decreasing inequality. And I think maybe the overwhelming thing that leaps out from this picture is a huge decline for blacks relative to whites, which is, I think, a good news story that nobody in the US is talking about at all. So the black rates are still higher than the white rates, but they've gotten much closer over this period of time. Looking at school-age children, you see a somewhat similar pattern. Here, the big story seems to be for males, really big declines in mortality, especially in the poor places relative to the rich places. So again, decreasing inequality in mortality. Then if we start looking at adults, we see something different. So especially if you focus on the graph to the left for white females, what these lines show is that mortality is actually higher in most places in 2010 than it was in 1990. Okay, so that's what a lot of people are writing about and upset about, and it is very sobering. Similarly, for white males, over about half of the counties, you don't see any improvement in mortality. For the poorest counties, you do see some decline in mortality. And then again, for African Americans, you're seeing declines in mortality, especially for black males. And then when we look at the oldest ages, not that old, I guess, but 50 plus, this is the group that has been focused on in most of the previous research. What you see is, again, declines in mortality, but now the decline is greater in the rich places than in the poor places. So that's the increase in inequality and mortality that people are talking about. Okay, so the takeaway, well, before I get to that, I'll just show you that I can do this a little bit more formally than just looking at the slopes of these lines and say, well, are these lines significantly different from each other? And for children, the answer is yes. All of these lines are much flatter in 2010 than they were in 1990 for male children and female children. For adults, for men, you see that the lines are flatter up until about age 50. Then they shift in a parallel way. And then for the oldest age groups, you see increases in inequality and mortality. And then for women, what I've indicated here in red are ages where you see increases in inequality and mortality. And basically from 45 on, you're seeing big increases in inequality in mortality. Okay, so what I take away from this is that there's very different trends going on in inequality and mortality for children and for adults, and that inequality and mortality fell for US children between 1990 and 2010. So that raises the issue of why. What changed in the US over this time period? There was declining poverty, there was higher spending on social programs. And the thing that I'm really going to emphasize is spending on one particular program, the Medicaid program, which is the public health insurance program covering lower-income women and children in the US. So looking at poverty, you might have been surprised if you followed these numbers for me to say poverty fell in the US, because we hear all the time that poverty has stalled in the US. And if you look at the official poverty measure, it's pretty flat. Over this period from 1990 to 2010, it kind of hovered around 20%. Okay? But the official poverty measure in the United States does not include the effects of any anti-poverty programs. So perversely enough, no US anti-poverty programs can affect poverty because they're not counted. The anti-poverty programs that make the biggest difference are an inward tax credit called the Earned Income Tax Credit, and supplemental nutrition program, the Supplemental Nutrition Assistance Program, or SNAP, which used to be called food stamps. So those two programs together, if you add them in, and various other in-kind programs like housing assistance, you get something that the Census Bureau puts out called the Supplemental Poverty Measure. And if you look at that, you see actually quite a big decline in poverty over this period. Okay. And looking at spending on those programs, the ones I mentioned, the in-work tax credit, the nutrition program, you do see the run-up in spending. But those are dwarfed by spending on the Medicaid program. The Medicaid program isn't included even in the supplemental poverty measure because of issues having to do with how you value health insurance. And people just thought that's too hard of a problem, so they don't include it. But this spending was accompanied by big changes in health insurance coverage. This graph is showing the fraction of 18 to 44-year-old women who would be eligible for Medicaid if they became pregnant over the period 79 to 1993, when this expansion for pregnant women was phased in. So this goes from 12% to 43%. So essentially every woman in the US now has coverage of pregnancy. This line continued to go up to the present moment. About 50% of births are paid for by the Medicaid program. Now, this sort of scatter that you see in the background here is dispersion across states, because although all of the states eventually arrived at the same point, they took different time paths to get there. And so there was a lot of dispersion that can be used to evaluate the effects of this program. Medicaid eligibility for children also increased greatly, and this was phased in by age. So first the youngest children, and then eventually the oldest children. And so you can see here about 15 to 20% of children were eligible for public health insurance before all of these expansions, and afterwards it's closer to 40 to 50% of children. Okay, so again, most children have health insurance now, and it's because of these programs. So another thing that you can see in the data is a flattening of the relationship between income and health. On the left is a reproduction of a quite famous graph from a paper by Case, Slobodsky, and Paxson, showing the relationship between family income, which is on the x-axis here, and a measure of poor health. So the negative slope shows that if you have more income, you're less likely to be in poor health. But the point they really wanted to make was how these lines kind of rotate with child age. So in other words, as the children got older, income became an even more important determinant of their health. So this was over the period 1986 to 1990 when they did that research. That precedes any of these health insurance expansions. And if you go to the early 2000s, what you see is that these lines have become flatter, right? So we haven't eliminated the relationship between income and health, but we've made it flatter, and especially for the youngest children who got these Medicaid expansions first. If you look at access to care, you see a very similar sort of pattern. So here the measure of access is whether the child had any doctor visits at all in the last year. And there's a negative relationship with income. Right? So you're more likely to have had any visits if you have higher income in 1986. But that effect declines as you go through the time periods. Okay? And again, it sort of declines quicker for the younger children. So I think I've led you to believe that health insurance may have something to do with this moderating of the relationship between income and health, but how could we go about trying to prove that? One way is to try and compare the US to somewhere else, and I'm going to argue that Canada is a good comparison. Why is that? Well, access to medical technology, habits like smoking, kinds of products that people use, how much they drive, all these sorts of drivers of mortality are quite similar. Also, Canada showed a similar decline in poverty rates over the period to what I showed you with the supplemental poverty measure. But there was a big policy difference, which is that over the entire period, Canadian children and pregnant women had health insurance because Canada has universal health coverage, whereas in the US, you had children gaining coverage. So what I'm going to do is do some comparisons by age and look to see whether something's going on that's different for the US children compared to Canadian children and for the other age groups. Okay, but before I do that, I'm just going to tell you a little bit about how mortality looks. Since this is Canadian data, I sort of think about this as a hockey stick of mortality. Well, what you see is a very typical pattern with high mortality rates for infants, which then fall very rapidly. So children have low mortality. Then starting in late adolescence, pretty rapid run-up in mortality, and then a sort of smooth increase in mortality into old age. Okay, so that's the sort of general age pattern. What you can also see from this is that the US, which is the blue lines, has higher mortality at every age than Canada, which is the green lines. You can also see that the thinner lines, which represent males, have higher mortality than the thicker lines, which represents females. Okay, so at every age, men have higher mortality than women, and Americans have higher mortality than Canadians. So if I do this kind of comparison that I was showing you, but now I overlay Canada and the US, this is the kind of thing that you see. Okay, so we saw figures for 0 to 4 for the US, which were like these blue lines here. So here, the thin line is for 1990, and the thick line is for 2010. And you see the greater decline in mortality for the poor places than for the richer places, so decline in inequality mortality. In Canada, there's also a shift down in mortality. You might think about that there's generally going to be some sort of shift if we have, say, technology and medicine that's causing improvements. But the point here is that this thick blue line is almost on top of the thick red line for the 0 to 4-year-olds. Now, if I look at other age groups, and we've done this by 5-year age categories all the way up, I'm just selecting some of them out here, you can see that for males, 40 to 44-year-old, we still see declines in mortality in the US, but there's a large gap that remains in 2010 with mortality in Canada. Okay? And if we look at the 60 to 64-year-old males, we see, really big decline in mortality in Canada, fairly big decline in mortality in the US, but a very big gap in the poorest places between mortality in Canada and mortality in the US. Okay, so that's for males. For females, the picture is somewhat similar, except that we don't see any improvement at all in mortality among middle-aged women in the US. And we see a very large gap in 2010 between mortality for middle-aged women in Canada and mortality for middle-aged women in the US. Similarly for older people. Okay, so this convergence to the lower Canadian level seems to only be happening in the child group, and that's the group that got health insurance in the US. Okay, so just to summarize these Canada-US comparisons, we saw that mortality for young and old fell. Mortality stalled, especially among middle-aged women. The US child mortality rate converged to a much lower child mortality rate in Canada, and we didn't see such convergence for other age groups. So again, since Medicaid is kind of the biggest social policy affecting children in the US, and it's also one of the largest policy differences between Canada and the US, I think this is suggestive that Medicaid was an important factor. Now, we can look more directly at the effects of Medicaid in the US using the fact that these Medicaid expansions were phased in. This map is from a very nice paper by Sarah Miller and Laura Weary that's looking at the effects of Medicaid on young adults and making use of the fact that places that were very stingy with their public health insurance to begin with had much bigger increases than other places. So this kind of variation was used in some early work by me and John Gruber and some other people to look at the effects of Medicaid expansions. And what we found was a large and immediate decrease in infant mortality, which was linked to increases in utilization of care. So for example, a 50% reduction in delay in obtaining prenatal care among the highest poverty groups. What Laura and Sarah have done, which is very nice, is to realize, well, those kids that were covered in the early 1990s are now adults. So we can follow over time and see, did those kids who were covered turn out to be healthier, more productive adults? So they look at data from a number of different sources and find that the cohorts who were covered are a third of a standard deviation less likely to have a chronic condition. They have fewer hospital visits, and that they were more likely to graduate from high school. They find even bigger effects among the poorest on chronic conditions, hospital visits, graduating from high school, and also start to find effects on some other outcomes. Did they ever attend college? What is their personal income? Do they use welfare programs? And interestingly, a large decline on a scale of mental distress. So this Kessler index is called the Kessler 6 because it's based on 6 questions and it's scored out of 24. So an average decline of 2 on this index is actually a pretty big decline. There's some new evidence from IFS researchers about the rollout of the NHS that's totally consistent with this. Wilson and Luhrmann, in work that they presented at the Summer Institute in Boston this year, showed that there was an immediate drop in infant mortality when the NHS reached an area, and they can follow people for 50 years after this initial rollout and see that there's a 14% reduction in mortality at age 58 in the affected cohorts. Among US children, we can also look at the effect of gaining Medicaid coverage, and here identification is aided by the fact that there was a quirk in the law that said that you could only be eligible for these Medicaid expansions if you were born after September 1, 1983. So if you were born in August 1983, you were just out of luck. You were never going to get public health insurance. So a number of different researchers have used that fact and looked at a bunch of different outcomes. One example is a different paper by Lara Weary and Bruce Meyer looking at hospitalization rates. So here you have the children who were born in the 50 months before September 1983, kids that were born in the 50 months after September 1983. You see that there was a declining trend in hospitalizations, but there's also a sharp discontinuity in hospitalizations for the cohorts who gained coverage. And in this case, this is Black 21 to 28-year-olds who had coverage as young children. A different set of researchers, Brown, Kowalski, and Lurie, have used the US tax data to try and look at the effects of Medicaid coverage for young children. They're using essentially the same design. So this map is showing that kids who were born in 1981 got many fewer years of Medicaid eligibility than kids who were born in 1984. And then they look at the effect of an additional year of Medicaid eligibility on your tax payments. Okay, so this figure is showing the cumulative tax paid between ages 19 and 28 by family poverty level at ages 15 to 18. And so, for example, this point here is saying that for each additional year of Medicaid eligibility, these kids paid on average $1,800 more in taxes between the ages of 19 and 28. Okay, so there's a lot of evidence of positive effects of these Medicaid expansions on things like productivity, earnings, and now I'm going to talk in the last part of my lecture about why I think mental health might be an important mechanism. One reason is that mental health is one of the most important determinants of adult outcomes, and I'll show you some data about that. Secondly, we know that a lot of mental health problems start in childhood or even prenatally, so coverage of children in the prenatal period might have an impact. And we know that maternal mental health has important impacts on children. So this is starting to change, but economists to date haven't really talked a lot about mental health. We prefer to talk about non-cognitive skills. Maybe that's less threatening to people. So just to take an example from a recent paper by Per Anders Eden and co-authors, they show that there's high and rising labor market returns to non-cognitive skills using Swedish registry data where every draftee was tested. And these terms are taken from their paper. The non-cognitive skills they consider are social maturity, what they call psychological energy or focus, intensity or internal motivation, and emotional stability or tolerance to stress. And I just want you to consider how you think those things might be affected by some of the most common mental health conditions, right? So if you have ADHD, then you might lack focus. If you have depression, you might find that your internal motivation is affected. And if you suffer from anxiety, then you're not going to be very stress tolerant, right? So there's a very close relationship between what we've been talking about as non-cognitive skills and what other people in other disciplines might talk about as mental health problems. These mental health problems are very common. So in the US, it's estimated that 4 to 6% of children have ADHD. The best estimate I could find for the UK was 3.6% of boys and only 0.85% of girls. But actually, experts seem to think that there isn't a gender difference in incidence, so this really reflects underdiagnosis of girls. Other statistics, I think this one's fairly astounding. 12.7% of Americans over 12 took an antidepressant in the last 30 days in 2014. Right? So I don't have a comparable statistic for the UK, but it is known that there were almost as many prescriptions for antidepressants in the UK as there were for high blood pressure, which is a very common reason that people take medications. Another way to find out about mental health is to ask people. And in the US General Social Survey, they ask people, how many days in the last 30 days was your mental health not good? Okay? So I think somewhat surprisingly, maybe 40 to 50% of people say they had at least some days in the last 30 days when their mental health was not good. Around 20% had 1 to 4 days, but over 10% say they had 10 plus days in the last 30 days when their mental health was not good. Okay? And this is fairly stable. The question's been asked since 2002 over all of these waves. So these conditions are common. They're also really costly in terms of both healthcare expenditures and working days lost. So one way to look at healthcare expenditures, or an important source of healthcare expenditures, is urgent care visits. And in the US, if you look at all of the urgent care visits for 5 states, which I've done, what you see is that there's a mental health code on 13% of them. And then if you look into, well, what are the common mental health codes that are on these claims records, 3% have substance abuse and no other mental health disorder. 5% have a mood disorder like depression, and 5% have an anxiety disorder. So you have a lot of people showing up to emergency rooms with these mental health conditions. This data, which unfortunately is a little bit old, is from a survey of workers where they're looking at people who had to take time off work because of a health problem, any health problem, and then dividing them up into people who had a mental health problem, which is the red bars, and people who had any other kind of health problem. So if you had to lose work because of a mental health problem, you're much more likely to be in this bar here, where you missed more than 30 days of work. Okay? So it's quite debilitating if you do have this problem. As I mentioned, mental health problems often begin in childhood and continue into adulthood and have impacts on adults. In some work using Canadian administrative data, I've looked at the effects of childhood mental health problems on young adults and tried to compare the effect of having a physical health problem, where common physical health problems are things like asthma and also injuries, to having a mental health disorder. And the ones we look at are ADHD and conduct disorder, which are both common. We look at the effects of diagnoses at 4 different ages, and also the effect of having a persistent diagnosis. We had 50,000 children from one Canadian province and their siblings. The records were merged to education records and also to records on welfare use. So we could compare children who are affected to their siblings who are not affected, and the outcomes we could look at were welfare use after age 18, being in grade 12 by age 17, having taken the right math courses in high school that you need to get into college. Okay, so here what I'm doing is just plotting out the estimated coefficients, and the main point I want you to take away is how much greater the impact of having ADHD or conduct disorder is than having either asthma or injuries. Okay, and especially if it's in the teenage years, you're much more likely to end up on social assistance after age 18. Okay? And similarly, if we look at whether you took a math course in high school that you would need in order to qualify for college, there's a big negative effect of having ADHD or conduct disorder. If I look at the effect of having a persistent health problem, that's worse, for asthma and worse for injuries, but the scale of the effect is really dwarfed by the size of the effect for ADHD. Okay, so these mental health problems can be very debilitating. We also know that prenatal conditions can place children at higher risk of poor mental health, and there's a long history of research in this vein, some of it looking at very extreme events like the Dutch hunger winter, where infants who were in utero while their mothers were starving are more likely to have schizophrenia. A similar study by Malaspina and co-authors finds a relationship between exposure to the Six-Day War in Israel and later schizophrenia. Some people have used registry data to try and look at less extreme health shocks, I guess. So for example, there's this paper by Peterson and co-authors using Danish data, finding an association between birth weight and ADHD, even in monozygotic or identical twins. A recent paper by Petra Pearson and Maya Rosen-Slater uses Swedish registry data and looks at the effect of having a close relative die while the mother was pregnant compared to just afterwards. And the reason for that design is that deaths in the family are not sort of random. People from lower socioeconomic status backgrounds are more likely to have a death in the family. So using that sort of treatment-controlled design, they find that the probability of using an ADHD drug increases by 25% in childhood, and then if you follow into adulthood, the children who are affected are more likely to be using drugs for anxiety or depression in adulthood. So, yeah, I said I was going to have some good news here, and this seems like kind of depressing so far. So a question is, can intervention in pregnancy prevent mental health problems? We discussed earlier the finding from Miller and Wary that there were improvements in the Kessler scores of children who were affected by the Medicaid expansions prenatally. More recently, I've been doing work with Anna Chorney looking at the effect of prenatal WIC participation on mental health in children 6 to 11 years old in South Carolina. So WIC is actually a nutrition program, but they're mandated to connect people. So this may be a little bit like Sure Start, which you mentioned. They're mandated to connect people to providers, and there's evidence that they're actually pretty effective in that. So people on WIC are more likely to get health care, even though they all have health insurance. And so we look at children who were born between 2004 and 2009, but who can be followed up to 2015 using the administrative Medicaid data, and look at whether they're being treated for mental health problems. And what we find is, here we're looking at ADHD, depression, and anxiety, and a sort of grab bag of all other conditions. So we find a negative effect of prenatal WIC on ADHD, also other mental health problems, and the effect is largest for African Americans and also for lower income people. So in terms of percent, this is about a 5.5% decline in the probability of ADHD in the full sample, and about a 9.5% decline in the probability in the African American sample. So they're quite large effects. Now, one thing you may be wondering is if access to care prevents childhood mental health problems, and we've had expansions of access to care, then why is everybody talking all the time about how rates of childhood mental health problems are skyrocketing? I think diagnostic standards are an important part of the puzzle, but another important part is changes in incentives facing providers to do screening. So other things being equal, if you get access to care, and that means that you get screened, you're going to find more cases. So in the US, if you look at the national medical expenditure data for children less than 17, what you see, first of all, overall, there's a decline in all prescriptions. But that's not true for ADHD. You see an increase in prescriptions for ADHD. Now, I can break up kids into those that have private insurance and those that have public insurance. The private insurance are this green line here, where there's a lower rate and no change in ADHD prescriptions. And then you see the public insurance line tracks the overall increase. So most of the increase is coming from the Medicaid caseload. And people always feel really negative about that at first when you tell them. It's like, oh, they're medicating all these kids and they shouldn't be doing that. But I think one of the reasons for this is a change in the structure of the Medicaid program, where they switched from a fee-for-service program to a managed care program where the provider gets a capitated fee for treating the child. And this made it much easier for governments to hold providers accountable for doing screening. It also provided a direct incentive to the managed care plans to do screening because they get a higher capitated payment if the child has a chronic condition. So we looked at the switch to managed care in South Carolina, which occurred over a fairly short interval, using a 60% random sample of all of the children in the state Medicaid program at any time between 2004 and 2015. We have two different empirical methods. One is an event study where we're just comparing all of the kids who were in the sample before the change and all the kids who were in the sample after the change. And the other one is a model where we estimate individual child fixed effects. So we're following the same child over time and saying what happens to the same child when they get defaulted into a different kind of plan. Okay? So if you look at the event studies, what you see is an increase in well-child screenings, and the increase in ADHD exactly tracks that. Right? So you're screening more kids, you're getting more cases. If you look at the child fixed effects models, you see that there's an increase in well-child screening, there's an increase in developmental screening, there's an increase in vaccinations, right? And these are all kids that had health insurance to begin with, right? And they all should have been getting vaccinated, but now they're really doing it. You also see a somewhat smaller increase in sick visits. And then if we look at diagnoses of different conditions, you see I've highlighted the mental health diagnoses here. So you do see an increase in ADHD, you see an increase in depression, but you also see an increase in all these other things. So you see an increase in diagnoses of asthma, mild infections, ear, nose, and throat, autoimmune disorders, right? So they're just finding a lot more stuff and treating it. And what I find is people feel very negative about medicating kids for ADHD, but they don't feel negative at all about medicating them for asthma, right? Which is one reason why it's good to have both in the comparison. So we've discussed prevention and diagnosis of mental health, and I want to spend the last couple of minutes talking a little bit about treatment. And of course, economists are not supposed to have anything to say about treatments, but I'm going to argue that maybe we can say something, and that the US can serve as a laboratory for understanding the effectiveness of treatment given very large variations in treatment patterns, which are at the individual doctor level. Also, there's increasing availability of administrative data on both treatment and some important outcomes that we can use to maybe look at whether certain treatment patterns are associated with better outcomes. So to give you some idea of the variety, this is a map showing for each county annual antidepressant prescriptions per person in 2014. You'd see some counties had more than 2 per person. Other counties had, none or very few. Similarly, if you look at what is being prescribed, well, different places have different favorite drugs. So here, these are all the generic names, but you might recognize the pink is Zoloft, the light green is Prozac, the light blue is Celexa. So those would be the brand names associated with those drugs. Okay, so they're prescribing at really different rates, they're prescribing really different things. And there are some treatment guidelines, not very precise, but an interesting thing is that they also differ by country. So NICE basically says, and this is sort of a gross simplification, but basically they say, well, start treating people with an SSRI, and if they don't respond to an SSRI, which is a class of drugs, then try a different class of drugs. Okay, so the Canadian guidelines sort of refer to the NICE guidelines indirectly because they say, well, even within classes, there are some drugs which are much more effective than other drugs. So if you're on a drug and it doesn't work for you, try a more effective drug. And then they have a list of which drugs are more effective. So they actually give you a ranking. The US American Psychiatric Association does not like guidelines at all, but they have sort of a grudging statement that says, well, most patients could be treated using these drugs. And interestingly, their list leaves out about 20% of the market, and the drugs they leave out are drugs that tend to have much worse side effects, okay, but are still being widely used. And then another thing that's common to all of these guidelines is that they don't like drug cocktails or polypharmacy. There's a lot of warnings about that. legitimately because most drug cocktails have not been subject to any kind of clinical trials. Okay, so in recent work with Bentley McLeod, we've been trying to evaluate what we call violations of these guidelines using claims data from a large American insurer, Blue Cross Blue Shield. We have about 600,000 people being treated for depression. We follow them every month, and we can use patient fixed effects to control for unobserved differences in their condition. And in terms of outcomes, we look at, well, what's the cost of their treatment? And did they end up having to go to the emergency room or be hospitalized, which are very bad outcomes for patients. So we look at the effect of a violation in treatment guidelines between months T-2 and T-1 on their outcome at time T. And a nice thing about this is we can look at all the different guidelines and see whether they have different effects on costs, for example. Okay, so when we do this, what we see is that violating these guidelines increases costs. Violating the Canadian guidelines increases it the most. Total costs could be driven by the type of drug that you're prescribing, whether it's an expensive drug or not. So we also look at non-drug costs, and you see a very similar pattern there. Also, polypharmacy increases costs. And then in the last column, although these are small point estimates, they're quite large relative to the overall mean. So in every month of our data, about 2.5% of these patients that are being treated for depression have to go to the ER or have to get hospitalized. And the probability of that goes up by 15 to 20% if their prescriber is violating one of these guidelines. Okay, so what I take away from this is that at least at a sort of crude level of saying, are there people out there who are practicing in a way that's really not very helpful to their patients? You can identify people like that using claims data. Okay, so to summarize then, what I've argued is that access to healthcare starting in the prenatal period improves child and adult health and productivity, and that the rollout of public insurance for pregnant women and children in the US and also here in the UK reduced mortality and improved adult health. In the US, we have reductions in inequality and mortality among children against a backdrop of increasing inequality and mortality among adults. And I argue that's largely due to these expansions of insurance, which brought child mortality rates in the US quite close to Canadian rates. I think prevention of mental health problems may be one of the important mechanisms for the improvements in overall outcomes in the affected cohorts. And although mental health diagnoses in children are increasing, this may be largely due to improvements in diagnosis, screening, and treatment, right? Because after all, if there's no effective treatment, then there's much less point in screening people or diagnosing them. And lastly, I would argue that economists may be able to contribute to evaluating the effectiveness of prevention and treatment using large-scale administrative data sets that have become available. So thank you very much for your attention.
That was absolutely brilliant. And so now we move to the Q&A. I'll just remind people there will be mics roving around the room. I'm going to take my chairman's prerogative here and just a lot of what you talked about there was about drugs. And I've been spending too much time hanging out with Richard Layard to not ask the question he would put, which would be about behavioral therapies and the like. Have you looked at those at all?
So we haven't looked that much, partly because, so what I was trying to do was show that economists could do something useful at all. And so I didn't want to kind of argue with treatment guidelines. I wanted to take some existing treatment guidelines and say, if you apply these guidelines or don't apply these guidelines, can I see an effect? So the problem with the behavioral health is the guidelines are much less clear about what should be done.
Constitutes, right, okay. because I think what he found was it was very hard to measure outcomes of standard drug treatments, and they worked on this IAPT program, which they were very clear about trying to actually evaluate it as they went along.
Right. So I think you can do that in the context of a randomized clinical trial. Look at one kind of therapy compared to another kind of therapy, and maybe you can do that using claims data as well. But I haven't done that yet.
Okay, brilliant. Okay, over to you, audience. Please stick your hand up if you're keen to ask a question. There are lots of mics all around, and. Looks like, Richard, you're going to violate my rule, which is normally the first question has to be asked by a woman. But since no woman's putting their hand up, I'm going to find that difficult, so I am going to let Richard.
Okay, Richard Blundell, IFS. You're kind of optimistic, pessimistic. I was trying to, but I want to think about going forward. We've seen this decline in, or increase in inequality, especially among poorer men or women, and yet you see this effect in the early years. So given your work, you could think of working through what's happened at early years and think, could that address, even reverse what we're seeing, especially in the US, but elsewhere, at older ages? Or are they just very different? Is there something different about what's happened at older ages, which is around opioid and other things that have happened, that an economic decline or whatever it is? Or are they, do you think they are linked sufficiently with these early years things that we might be optimistic about the trends going forward for the older ages?
Yeah, I think it is a more optimistic picture than has been presented, because people tend to look at the current middle-aged and elderly and assume that the situation for children is going to be the same in 30 or 40 years when they get there. And it looks much more hopeful. They're starting from a better place. If they have better mental health, maybe they'll be less likely to end up abusing substances of various kinds. And so at least there's, I think, a lot more hope there that will be a much healthier cohort. The other thing I think people forget with the current older cohorts is there's things like smoking, right, which can have very long-term effects. And so we see, for example, the health of middle-aged and older women is not that great. Well, women kind of got the memo later about stopping smoking than men. Particularly less educated women smoked longer than most other groups. At least it peaked much later. And so you may be partly seeing the effect of that working itself through the older cohorts. And it may have nothing to do with current conditions. It may have to do with things that happened a long time ago.
Yes, question there.
Carol Proper, Imperial College. Thank you, Janet, for, as usual, a fascinating talk. I was kind of interested in the stuff you were talking about on guidelines, because there's a lot of, as you pointed out, there's a lot of resistance by the medical profession, particularly in the US, for using guidelines, but your work is showing actually, well, guidelines can have some benefits. So why do you think there's such resistance to the use of guidelines? And what do you think that the kind of impact that your kind of work that takes admin, economic data to the medical profession might be?
Well, I think the resistance is the same reason that professors don't like teaching evaluations, right? Nobody likes having somebody looking over their shoulder or telling them how to do their job. Also, doctors, I think, feel that they get enough criticism, without having guidelines restricting what they can do. In terms of how much influence this might have, I think it could have some eventually. It has to sort of feed down from the academic medical centers where people are more interested in this kind of research to the training of individual physicians.
Okay. Yeah, question back there. Yeah.
Hello, Tim Loynig, British Government and London School of Economics. I was wondering about benefit-cost ratios. You've shown us, I think, pretty compellingly that there are some interventions we can do, particularly with pregnant women, and that there are potentially quite large payoffs later on because the kids are more likely to go to college and pay more tax. And I just wondered whether you had any sense in the sort of conventional benefit-cost ratio that we economists love. Is it great? Is it marginal? What does it look like?
Right. So the Brown-Kowalski and Lurie paper does benefit cost in the sort of traditional sense of saying, like, well, are the benefits large enough to totally offset the cost of the program? But they're not. I think, you know, depending how you do the calculation, maybe they offset a quarter of the cost of the program. I always feel a little bit impatient with those calculations, right? Because you sort of think, okay, like, what is the government supposed to be doing if not making people happier and healthier? And shouldn't we be willing to pay some money for that? Or, you know, do we really expect every social program to pay for itself, no matter if it's doing what it's supposed to or not?
And I guess if we measure benefits in QALYs, you'd get it as clear, and that's what we're trying to do.
Well, a really interesting frontier in this research also is looking at intergenerational effects. So there's at least one study now looking at the, you know, as I say, these kids who are covered are now young adults, so they're having children themselves, and you can see positive effects on the birth weight of the grandchildren of the woman who was originally covered. So I guess if you're going to do a really serious job, you'd have to put in those multiplier effects as well and think about, you know, are we going to be able to attack inequality in this way by, you know, gradually reducing these differences between people?
Great.
That was my question there.
All right. Okay. Yes, there. Mike,
Thank you. You talked about the...
could you say who you are first?
Oh, sorry, Claire Belfield. You talked about the increasing diagnosis of mental health conditions. Are you able to say what effect different technologies, particularly the use of social media, has on that?
So I can't actually speak to that. I do think that's a really interesting question, and I think it's possible that, especially for adolescents, that social media is having a negative effect. There seem to be lots of people who believe that that's the case. I haven't seen very good research examining that.
I think we're about to get some good evidence towards the end of this year in the UK on prevalence, which for the first time I think has lots of questions about social media in it. So might be something we can start to do more about when we get better data. Yes.
Hi, Aditya Agrawal, NHS England / NHS grad scheme. So thank you very much for the really insightful talk. Really enjoyed hearing about mental health. I've just come on the back of a placement in mental health. So I wanted to ask if you had any research or outcomes that explored physical health effects or improvements in physical health alongside the improvements in, say, the mental health, because I remember going to a talk, I think, last year, and they said about how when an individual's mental health deteriorates, one main thing which is quite often missed is the deterioration in oral health, and I think it's about, you know, deteriorates by about 40%, which may not have which has a short-term impact, but then has a much longer-term impact of, you know, when the individual's health improves, then suddenly their teeth have fallen out essentially. So I wondered if you had any, if you had explored that in your research. Thanks.
Right. So I think a lot of that research may be looking more at older people. So younger people, it might take longer for negative mental health shocks to have an effect on their health. But Anna Chorney has done some interesting work, and I think there's also some work done using the Danish registry data, looking at the effect of treating kids for ADHD on injury rates. And you do see pretty consistent effects of reducing injury rates of treating kids. So it's interesting. I think a lot of parents who put their kids on ADHD drugs do that with the anticipation that it will improve their schooling attainment. There doesn't actually seem to be very much evidence that it does improve their schooling attainment, but it does improve their health by preventing injuries, by preventing STDs, by preventing problem drinking. So there seem to be effects on a whole range of health outcomes, as you suggest.
Sorry, the question was the interaction between physical and mental health. Yes.
Hi, good evening. Ben Fletcher from NHS England. You showed some interesting data comparing people on private insurance versus people on public insurance. I wondered if your data allowed you to track children who had moved between public and private insurance during the course of the study, and whether you saw any changes in how their outcomes went when they moved from one to the other.
Yes, so I haven't been able to do that. The first data that I showed you was from a survey, so they don't track people over time at all. It's a cross-sectional survey. And then the second data that I showed you was from Medicaid claims data. So I don't have the, you need what in the US we would call an all-payer claims database. And I don't have that for South Carolina.
There's a question at the back. Oh, all right.
Tom McBride, Early Intervention Foundation. I think there's two hypotheses running through your talk on what's behind this improvement in outcomes that we see. One, that there's a reduction in prevalence of mental health problems for children through the insurance of expectant mothers. And secondly, there's an improvement in prognosis for children with mental health problems through better identification and treatment. And just trying to understand, is that the hypothesis? And if level in service use or any other data between insured and uninsured cohorts gives you any handle on which of those is the most plausible or which is the biggest driver of these outcomes?
Yeah, so it's definitely hypothesis. It's somewhat difficult to test, given if it's really true that a lot more kids are being identified with these disorders than used to be. Right, then we have all the pre-period being kind of full of people who were not observed. And so it's hard to know well, presumably they didn't get any treatment either. So we don't know kind of what share of negative outcomes was due to a bunch of people who had some sort of mental health problem who maybe could have been helped and weren't helped. So it's hard to test.
Yes.
Hi, Horacio Atanasio from IFS. Janet, going back to your positive news and the decline in inequality among young children, and you seem to hint that it was quite linked to Head Start and food stamps and the like. Do you have an idea about what did this program do? What are the mechanisms through which these impacts were obtained?
So I guess the program that I was really emphasizing was the health insurance program. And I think it covered pregnant women, which seemed to be quite important. And it also covered children from birth, essentially. So the kids who were covered from birth seemed to have much better outcomes in terms of fewer chronic conditions than other children. So that was the mechanism that I was mainly emphasizing.
David Phillips, IFS. So the results you presented were mainly about the expansion of health coverage, which is clearly of a big interest in the United States. But in many European countries like the UK, health coverage is universal. So I was wondering, have you kind of almost used that as an instrument to look at, the number of prenatal visits people get or the kind of treatments they get in advance? Because whilst we do have universal coverage here, maybe we could have more intense kind of interventions in prenatal areas. So I wondered if you'd actually use it as an instrument to look at the intensity of prenatal or postnatal or early childhood care.
Yeah, I guess the work that I was talking about with WIC has a little bit that flavor, in the sense of here's a bunch of people who all have health insurance. Now, some of them are getting a more intensive service where they get directed to a provider, or when they come in to get their food benefits, somebody says to them, like, hey, did you go get your prenatal care visit this month? And that seems to have an effect. So that's one sort of example. Another example is just this change in the structure of the program from fee-for-service to managed care, where they changed the incentives for the providers, and then you see people getting a lot more care, essentially. So again, they all had insurance, but if we change the structure of the program and give the providers incentives to screen, then they screen more. So.
Could I just sort of, partly following up on that, I was very struck by your chart about using the data at US county level on the level of prescriptions, you know, the numbers at 0 and numbers at more than 2. I mean, that seems bizarre that there should be such a variety. I mean, is there any, do you think we'd find that in the UK if we had that detailed data? And is there, have you got any hypotheses about why there's those differences?
So at the IFS workshop today, there was one paper that was talking about provider differences in the UK in a different context. But yes, I think there probably would be a lot of variation. And in the US, so I showed you these graphs by county level. You see the same thing if you look at hospitals. You see the same thing within hospitals. You see like lots of doctors just doing completely different things. Interestingly enough, where you have stronger guidelines, you see less of that. So I've looked at a number of specific health problems. And for hip fractures in the US, there was no variation. So apparently everybody agrees if you have this kind of hip fracture, you get a hip replacement, and if you have this kind, then you get something else, right? So it just shows that if you have a guideline, then you get less of this variation, which could be good or bad.
Is it the physical versus mental? I mean, if you were, I was going to say, yeah, broken leg, hip, you'd kind of expect there's a set treatment.
Well, no, you see a lot of variation in heart surgery.
Yeah.
For example, you see a lot of variation in C-section rates. People talk about that a lot. So a lot of these common procedures, you see a great deal of variation. It may be that it's even more so for mental health because there's more different kinds of treatment. You know, so when people study cardiologists, you go in with a heart attack, there's 3 things they can do to you. So they can choose different ones, but there's a limited palette. Whereas if they're going to treat you for depression, over the time period that I was looking at, there are 32 different drugs. There's different kinds of therapy. And a lot of people who have depression get prescribed anti-anxiety drugs. There's a whole raft of those. They might get prescribed atypical antipsychotics. So there's, you know, hundreds of thousands of combinations of things that you could be prescribed. So it's maybe more difficult to...
So this naive idea that there's a best treatment and that people should have that is just that the evidence isn't strong enough for there to be a unique best treatment.
It's very difficult to establish what the best treatment would be in the way that we currently go about it, trying to have a clinical trial. So you have all these hundreds of different drugs. Okay, so you have a clinical trial, you have a small number of people, you exclude anybody who's suicidal, right, from the trial, because you can't have suicidal people in your trial. So the people who most need the treatment are excluded. And then you also have all these possible combinations, right, or sequences of drugs even. So many people are ill for a long time, so you could have, you know, this treatment and then that treatment and then this other treatment, or, right? So the idea that we're ever going to have enough clinical trials to look at all the possible combinations is just, you know, it's just not going to happen. So we do have all this claims data. We see the treatment patterns that are naturally arising from whatever physicians are doing. And you can identify, I think, at least at sort of a 10,000-foot view, things that are helpful and things that are not helpful. And then maybe there would be some guidance for what things should be evaluated using clinical trials. Right? So I think the best thing would be a combination of using social science methods, big data, machine learning, I might as well throw that in, and the more traditional way of doing things. And it would be great if we could get doctors on board with a sort of broader palette of ways to learn than saying that everything has to be only in a randomized clinical trial, just because we're never going to learn enough about this in that way, I think.
Okay, thank you. Yes, sir. There's a mic coming.
Imran Rasool, IFS. Janet, in your talk, you've spoken a lot about treatment, and I was wondering what good evidence do we have about prevention? So what types of policies have been effective in building resistance amongst children to begin with?
Yeah, so there are some smaller scale studies of interventions, some of which are effective. I mean, there's the work that Jens Ludwig has been doing in Chicago, teaching people sort of how to deal with interpersonal conflict. So I think there are some sort of promising approaches to helping people that already have mental health problems. I don't know that there's a lot of work being done sort of at the population level, more like what I was talking about today, trying to say, well, if we improve people's circumstances, will we reduce the incidence of mental health problems in the first place?
More questions? Yes.
Hi, Alice Wickersham, King's College London. I was just wondering if there's been any work in the US that you know of linking administrative data sets on mental health or health coverage and educational outcomes in children and young people?
So there's the work that I mentioned using Canadian data to look at that question where people had much worse outcomes. I've also done some work using survey data, the National Longitudinal Survey of Youth in Canada and in the US, comparing outcomes of children with ADHD and other mental health conditions. So that basically shows that kids with mental health conditions are ending up with lower educational attainment. It doesn't really say anything about treatment, though. So.
While people are thinking, just one question from me overall. So you studied the US and Canada, and there's some of the evidence about the UK. Is there anything that the UK can learn out of all of your research that we should steal from the US and Canada? What should all these people from NHS that are here today, what should they go away with? What's the message that, what should we do that would have the most impact in terms of improving overall health?
Well, if I could make a bold statement, making the administrative data available to researchers so that they could analyze what treatments are effective, and then you want to subject that kind of research to very critical scrutiny, but if it holds up, letting that actually influence policy, I think that would be good.
Mm-hmm. Okay, more research. Yeah, that's usually the answer.
Yeah, but to be fair, it is very difficult to get access to these data. And in Britain, you have fantastic data, right? There's all kinds of questions that could be answered. And you don't have to spend a lot of money to answer it either, because the data's already there, right? And you have all these wonderful students and researchers who want to analyze it. All the incentives are aligned. It just has to be made possible for people to do it.
Right. Okay. And just, sorry, you mentioned in passing something I hadn't really thought of, which is obviously really important. The problems about people who are suicidal. I mean, is it, and you talked about the need for more research, but just said you can't do any research on them. I mean, do you know, is there any way that one could solve that problem?
Well, so one thing I'm kind of proud of, although I didn't, make a big song and dance about it, is using ER visits as an outcome, I think is a real innovation, because the problem with studying suicide, suppose I wanted to study suicide and link it to prescriber behavior at the county level.
Right.
I can't do that, right? Because thankfully suicide is a rare outcome, so I'm just not going to be able to do that. Yeah. ER visits are not a rare outcome, right? And like 13% of ER visits have something to do with mental health. In the US, if you phoned, look in the phone book, pick any psychiatrist, phone them, the answering machine message you will get is, if you're having a crisis, go to your nearest ER. So it's a very meaningful outcome. Mm-hmm. It's much more frequent. It's related in the sense, people are harming themselves, ending up in the ER. A lot of people end up there many times before they actually kill themselves. Same with drug overdoses. Right? So I think it's a much more sensitive measure that's related to what we want to look at.
Okay. So that would be a good way in.
Yeah.
Good. Good innovation. Yes, sir.
Andrew Keckwick. What is the likelihood of your excellent proposal of social science, statistical methods and machine learning being used to answer some of these questions being adopted widely?
Well, I think it is being adopted widely. It's slow to make progress, but I think more people are doing this. And if you can show that you can generate some kind of meaningful results, then more people will be interested in doing it. So I thought it was interesting that I could take these guidelines, which are pretty vague, and show that if doctors violate these guidelines, their patient ends up in the hospital. Okay, well, there are lots of doctors violating these guidelines, so there's a start, right? You can take data, you can identify people. It's the same thing. I've done sort of similar stuff, as I say, looking at C-sections, looking at heart attacks. You can identify in claims data doctors that are killing people. It's not that difficult, right? So at least at a sort of first order, looking into people who require maybe some attention or explanation about what they're doing would, I think, be useful.
And publication of that data can be pretty powerful. Death rates by hospital or by doctor, for example.
Well, there was a study in California where they linked death data to a prescription drug registry. So they identified people who had died of drug overdoses, and then they just sent a letter to the doctor that said, by the way, your patient X died of a drug overdose, and we thought you might want to know. And the thing is, doctors don't know, right? So somebody shows up, you give them a prescription, and then you never see them again. You don't know what happened. Did they die? Did they go somewhere else? Did they decide they didn't have pain anymore? You have no idea what happened to them. So just, it doesn't necessarily have to be a punitive thing, right? Mm-hmm. It could just be more informational that you tell doctors, like, look, oh, you did this, and here's what happened. And then they saw, by the way, that doctors reduced their prescription of opioids when they were informed that somebody had died.
That seems good. Sir.
Thank you very much. My name's Paul Hudson. I've retired from academic life for about 15 years, so I have no affiliation. Thank you very much for your talk. I found it very interesting. One of the things that occurred to me is, I think it's the case in nearly all the Scandinavian countries. You have socialized medicine and National Health Service. It's free at the point of delivery. Finland, I understand, has a very high rate of suicides compared to many other European countries. Now, I've heard it said, I don't have any qualifications in this area, this is attributed to very long night times, actually, in the winter. And I wonder whether a similar sort of pattern in the United States and in Canada, it may be this higher incidence of suicides in the most northerly states of Canada and America than compared to the more southerly states.
There's a very testable hypothesis.
That's true. So I don't know the answer to that question. I guess what people are really concerned about in the US is sort of a rapid increase in suicide rates, which can't probably be explained by changes in the amount of sun. So I think the level differences might be explained partly that way, but not the trends.
Okay, we have time for one more question. Who would like to go with it? No? Yes, sir. Final question is yours.
Thank you. Alan Jodes. Could you say something about the coverage? You said most of the women are now covered. Did the Affordable Care Act bring coverage to more people? And is it possible that potential changes to the Affordable Care Act will see some people drop out of access to care?
So the difference between eligibility and coverage is actually pretty murky, especially if you have a very large group that's eligible. So what was happening with these pregnant women, and happens actually still to quite a large extent with Medicaid, is that you don't actually have to be covered to get care if the provider knows that you're eligible, because you can get covered retroactively. So for maternity care went from being a hospital's largest source of uncompensated care to being something where everybody was covered, essentially. So they could always get reimbursed for treating pregnant women. So then that changes the dynamics quite a bit, in that anybody who walks in, we know, oh, you're a paying customer, so we can treat you, instead of trying to, make you go somewhere else, for example. So in the US, when this happened, there was sort of a general equilibrium effect of hospitals opening maternity services or expanding maternity services, advertising maternity services. Where I lived in Los Angeles, there were hospitals that were giving away car seats, come have your baby here. So all of a sudden they wanted these customers, which they didn't want before. And that, it really didn't matter whether they were covered or not, because everybody knew that they were all eligible.
Just shows the power of the incentive effects, and this is, for us in the UK, a kind of, my God, the idea that, sorry, they just shoo you off if you arrived and you're ill. No, sorry. It's unthinkable in some ways for some of us.
Yeah.
Janet, right, I should say thank you very much for everything you've told us today. It's just, to me, there's so many issues that you raised there, so many important questions. And the capacity to make such dramatic improvements, if we could actually work out what this is doing and how you might prevent and treat these sorts of issues, particularly with mental illness and prevention of suicide. It just seems that this is a fundamentally important area. And as you've said, more research needed, which is a pretty good message for the IFS as well. So Janet, thank you very much. Brilliant.